Okay, this is Chapter 11 on evaluation design, the basic principles of single system design. And you'll recall earlier we talked about the differences between single system designs and classic research designs. I think I did that in the first lecture. Evaluation designs or single system designs are an arrangement of observations. Observations are, every time you give a measurement, a standardized scale, or any time that you do an observation, anything that you graph, that's an observation. Arrangement of observations before, during, and after implementation of an intervention. And there are many uses of single system designs. You can assess and monitor change, and if you'll take a minute and turn to page 295, it's actually in chapter 12, but that's okay. And it's a simple this A-B design, page 295, figure 12.2. You can see there's the baseline and intervention. On the vertical axis is the number of articles left out, maybe by a child, and then there's some type of intervention, maybe some type of reward program, some type of consequences, and then the number of articles left out goes down. So this intervention, you would say, looks like it's pretty successful. It's not completely successful, it looks like, yet, but so on the horizontal on the horizontal you have time. In this case it's days. The vertical is whatever you're measuring. Vertical axis is whatever you're measuring. This case is the number of articles. Okay, so you're able to assess and monitor change, as we saw in that graph. You're able to determine whether a change in intervention is needed. For example, in the case that we just looked at, there looked like there was change, but over weeks, if the intervention, if the number of articles stayed around 11 or 12, and you wanted to get it down further, maybe you'd want to implement another intervention or add another intervention. Also, you can somewhat determine whether an intervention caused the observed change, and I say somewhat because we'll talk about the whole concept of causality. In the graph that we're looking at, we can't always assume that our intervention is what caused the change. There might have been another event that happened. There might be a change in how it was measured. So we're going to talk about causality later in this chapter. But to some extent you can determine whether the intervention caused the observed change if you're able to eliminate and determine that eliminate all the threats to causality. And you're somewhat able to compare the relative effectiveness of interventions. And there are some caveats to this as well. You're not able to compare non-adjacent phases that are next to each other, and there are some complications, so we'll talk about those. Key characteristics, we'll talk about all these. Different phases, comparison of baseline and intervention phase. And then when you need to change your intervention and design, which depends on how your client's doing. In terms of phases, A phase is a period of time during which a distinctive evaluation activity occurs. Okay, and phases are separated by vertical lines in your graph. A always represents baseline phases, and B through Z represents intervention phases. So if you have A dash B dash C, then that would mean your A is your baseline, B is an intervention, let's say cognitive behavioral therapy, and then dash C would mean that you stopped your cognitive behavioral therapy and then you started a new intervention, let's say some psychotropic medication like Paxil or something. If you have two letters together, like BC, CD, that represents multiple interventions. So if you had A dash BC, that would mean that you did your baseline and you stopped, started your intervention, and your intervention was composed of your cognitive behavioral therapy in addition to the psychotropic medication. B, superscript 1, superscript 2, superscript 3, that represents changes in intervention intensity. If you have your client on an exercise program, you start them with 10 minutes a day, then the next week you move it to 20 minutes a day, and then maybe 2 weeks later 30 minutes a day. That would be represented by A dash B1, B2, B3, because you would changing your intervention intensity. You could increase the number of AA meetings people went to. It's not always an increase either. It's just a change in intensity. So you could have a situation where you're decreasing, like for example, dosage in medication, and you wanted to see if that affected the level of person's depression. So if you had somebody on 30 milligrams of Lexapro, and then you 3 weeks later took them down to 20, and then 10, then you could also represent it by A dash B1, B dash B2 dash B3. Okay. Phases. In terms of length of phases, you want a phase long enough to obtain a clear, representative, and stable picture of what's going on with the client in terms of their target behavior, whether that's depression, anxiety, etc. Normally for a baseline, you have 2 to 3 weeks to do this. You assume, from intake to first appointment maybe, or at least 2 weeks. So if you're taking weekly data, that's 2 or 3 points. If you're taking daily data, that's more. And then the book recommends that adjacent phases should be of equal length, ideally. And this is, from a research perspective, goes back to a baseline being compared to a control group, and an intervention group compared to a treatment group. So you want equal number of observations or people in those control groups. But however, practically in single system designs, it's often not impractical to have, if you plan a 12-week cognitive behavioral therapy, you're certainly not going to keep your client on a 12-week baseline. That, would be unethical, and the insurance wouldn't pay for it. The times that you can do this, if you have retrospective baseline, for example, if you do it looking at an agency and you're looking at the number of missed appointments, and you have records of that, then your baseline can be of equal length of your intervention, because you have that. It's called retrospective based data, or it's just you have records of it. So, and then finally, comparison of non-adjacent should be done with care at all. It's not a good idea to compare. For example, if you had an A-B-C design, wouldn't be a good idea to compare your baseline with your C intervention, because you had a B intervention in between, and you have what's called carryover effects, and we'll talk about that. You first, in order to you want to do something like a experimental design, which we'll talk about later, where you had an A-B-A-C, if you could do that. But it's never a good idea to compare phases that are not next to each other. That's the basic point. Baseline phase. This is, sort of your perfect baseline phase, where you have something that's stable and predictable and not variable. You have a clear picture of where the client's depression level is during baseline. Here you have probably unrealistic to have 4 weeks, but and then you could have a baseline that looks something like this, that's not predictable and that's variable. So in this type of situation, you would maybe consider, okay, is my measure, are all my baseline measures look like this? If they do, then you may want to ask your clients, what's going on in, week 3, was there something particular going on? How was when and how was the measure administered? Try to determine why it wasn't predictable, because really you need a stable baseline for the basis of comparison. If you're going to compare it to the intervention, you need a stable baseline. So baseline period is a period of time during which no formal intervention is implemented, and usually it's implemented before the intervention. Exceptions are if you have a client coming in a crisis situation. You certainly wouldn't say, well, we need to take 3 weeks of baseline before we can treat your suicidal ideations. You would just go into treatment, and you would have, maybe a B-C or a BC design, and then maybe a follow-up. There are times when it's impractical to get baseline data, but often during intake you can at least get one baseline data. So it's really, because it really is important to know where the client starts, even if they are in crisis mode, sometimes you can get some baseline data, even if it's just 1 point, even if it's just one observation. Intervention phase. This is a period of time during which formal, planned, systematic practitioner actions designed to change a target take place. In your intervention section, I asked, once you reviewed approximately 3 interventions, you chose the interventions that you described those to the extent that somebody else could come in and perform that intervention. So it's just not an eclectic mix of things. This is something planned and systematic that you have put into place week by week, or maybe week 1 to 3, week 4 to 6, something like that, so you know what you're going to be doing. During the intervention phase, as I mentioned before, you can either do one intervention or a combination of intervention. The advantage of doing one intervention is, if it works, you know that intervention worked. If you do a combination, then you may not be clear about which one worked. But then again, the important thing is the client getting some relief, the client getting better. Obviously should be clearly related to the problems and or goals. If they're not, then you really need to reevaluate your whole strategy, because you're treating something that that's why I had you go through the process of selecting the problems, prioritizing, negotiating with the client and deciding what problems you should work on, and then from that develop some goals with your client. And just reiterating the first point I made on this slide is that the intervention phase should be specified clearly. And then sometimes there's a follow-up phase. Some agencies, some practitioners like to, after they have some type of formal closure with their client, call them up, a month out, 2 months out, maybe 2 or 3 follow-up times, and give them the same measures that you did during baseline or intervention, or selected measures, to determine whether or not the change is holding. And if it's not holding, if they are regressing, then that would be the time where you may suggest that they come back in for maybe what's called a booster shot intervention to get them back on track. Comparison of baseline intervention phases. This is what's in order to determine change. You compare the baseline data with the intervention data. And on page 295 we looked at that example. And the assumption is that when you're doing your analysis of data, the assumption always is, if the intervention had not occurred, the baseline pattern would have continued unchanged. And this is a very important point when we talk about data intervention. I'll underline it even more, but I want to start talking about it now. And so, for example, for this example, when we talk about changes, looking at whether a client has changed or not, this is an example of where a client has deteriorated. You can see during baseline they had a stable baseline of 40. So the assumption is, if you hadn't intervened, that would have continued. So the best way is just to draw a line across here, and if this wasn't, if I was on a chalkboard, I'd be drawing a line on a marker board, drawing a line across there, and the line would at week 6 be at 40, but instead you're at 60. So clearly you compare where you would have been during, if there hadn't been an intervention, with where you are now since there's been an intervention. And here we talk about a change in level. What a change in level is the last, you compare the last baseline point with the first intervention point, and that's a change in level. So clearly there's deterioration here. When you talk about client change, you can talk about a client has improved, deteriorated, there's been no change, or it's ambiguous. You can't tell by the data that you have. Here's a difference in level. Again, level, the difference in the last baseline point and the first intervention point. Here, if we continue this baseline line out, we'd end up at 40. We compare that to where the intervention is at 20, and we can say, okay, our client improved. Adding to our vocabulary, also, in addition to talking about changes in level, we can also talk about differences in trend. We can talk about differences in slope, the slope of the line. So in this baseline example, you can see that you have an upward slope, and if left uncontinued, if left, the assumption would be that this slope would continue upward. And there's probably, when there's a slope like this, there's probably some type of ceiling effect, so it would probably end up over here. It's not going to, pop up all the way up to the top, but you're going to have, a general trend upward, we assume. That's the assumption. Okay, so you would end up about here. Instead, your trend totally changes. Now you have a downward trend. So this is a clear example of client improvement. Just the opposite. Here you have a client during baseline getting better. And here you might want to evaluate whether you should even treat this client until the baseline data stabilizes, or if the assumption is that the client is going to continue to get better, maybe you should just wait to treat this client to see whether this pattern is going to continue. So in this case, the assumption is that, again, this is going to keep going downward, and there's what we call a floor effect, so it won't, continue, like this. It'll continue sort of bottom out. But clearly, there's a change in trend. There's now, in the intervention, your client is getting worse, so you can clearly see that that your client, there's deterioration here, and your client's getting worse. Here we have no change, because again, the assumption is that your client is getting worse, and the assumption is that your client, that the pattern would continue, and your client continues to get worse. So there's really no change in this case. And here's an example that shows a difference in level and trend. So you have a downward slope, and then also a change in level. Both of them are show deterioration. There are situations, where you want to change your intervention. And as we've alluded to in the past, interventions, again, single system designs are dynamic. They're not static, and changes are based on client, how the client is doing. So interventions may be continued, or an intervention may be added during a phase, may be removed if it doesn't look like it's effective, replaced with another intervention, or changed in intensity. The change may be in response to deterioration of a target, of a client's problem, or change in response to insufficient improvement in the target. So if you're doing cognitive behavioral therapy and you're getting improvement but it's not fast enough, you may elect to refer that client to a psychiatrist and start some psychotropic medication. So you would have an A-B-B-C. So you continue to do the cognitive behavioral therapy, but you would add to it the psychotropic medication. And then finally, the intervention may change in response to the attainment of a goal. For example, if a client improves faster than you expect, there's no reason to continue treatment. So, or you may want to switch to another intervention and start working on another problem. Again, the design is dynamic, not static. When you start out with a client, you should have a planned design in mind. You may have a simple A-B design plan, but you may need to modify that in response to how your client reacts to your planned intervention. Potential complications. Carryover effects. And I was going to, hold on just a second. Potential complications are discussed on page 271, so I invite you to read that if you don't understand my explanation of it. Example carryover effect is where one example is where you may have what's called an experimental design, where you may have a A-B-A-C, where B is a cognitive behavioral therapy and C may be psychotropic medications, just keeping with the same examples. Carryover effects play into account when you have an intervention that's irreversible, where learning takes place. Cognitive behavioral therapy is a therapy where learning takes place, and you can't really, take that little module out of the client's brain, go back to baseline and start another intervention, nor would you want to. But you've got to recognize that you cannot retrieve, you can't go back to your original baseline because learning has taken place. Now there's some interventions that are reversible. You could argue that are reversible. I think it's hard to come up with one. You could say exercise, you could stop exercising, stop going to AA meetings, stop going to, but again, learning taking place at AA meetings. Exercise, you're going to have some physiological changes that can't be reversed immediately over time. go away. Medication, there's medication sometimes, there's, depending on the half-life, that it stays in your system for a while. So it's really hard to come up with an intervention that's not a reversible token system where you take away or a reward system or a consequence. But even in those situations, you could argue that learning took place and that there may be some carryover effect. It may be less than like a cognitive behavioral therapy where you learn skills and use skills, integrate skills. But anyway, that's what a carryover effect is when, like, you have an A-B-A-C design where you want to determine the effectiveness of C, and in order to determine the effectiveness of C, you use an experimental design, and in order to do that you want to retrieve your baseline. Now, you may recognize that, well, if you're treating a client, you're retrieving your baseline, you're stopping treatment, there may be some ethical concerns there. But there may be some reasons to do that as well. Going on to contrast effects. Example of this, just, I know this never happens, but let's say that there's a problem on campus with students parking in faculty spots. So they've collected some data about the number of times that happens per day, and they decide to implement a fine, a ticket, give tickets, and send out people to put $5 tickets. And that's their B intervention. And that doesn't have any effect or very little effect. And you can see why. You can probably see why. Well, you know, $5, you know, it's worth it to park closer on a building, especially on a cold day. So they then implement a $50 fine. And so now we have an A-B superscript 1-B superscript 2, where you're increasing the intensity of the intervention, you're increasing the level of fine. Okay, and they do this, and the students who were previously getting $5 fines are getting $50 fines, and there's just tremendous outrage on campus because this is a tremendous burden. It's a lot of money. There's letters to the editors, students marching on the administration building, whatever. What the contrast effect here is, if they had started out just with a simple A-B design and started out with a $50 effect, you probably wouldn't have gotten that reaction from the students. But what happened is that what the students are reacting to is the contrast between the $5 fine and the $50 fine. So that's what's called a contrast effect. The next complication, order of presentation effects. If you have two interventions that you want to use on your client, maybe cognitive behavioral therapy, followed by, I don't know, motivational enhancement therapy, A-B-C. That would be different than going from baseline to doing the motivational enhancement therapy first and then doing the cognitive behavioral therapy first. And so that it's hard to look at the effect of the cognitive behavioral therapy or the motivational enhancement therapy because of the order of presentation. Again, you're interventions are not irreversible. So the way this is handled is sometimes, maybe on one client you try it one way, and then on another client you try it another way and see which works better. But recognize that there is a order of presentation effect most of the time. And you could even have another example, maybe A dash B being cognitive behavioral therapy dash C being exercise. That may work differently than A dash B being exercise, doing exercise first, dash C doing cognitive behavioral therapy. So just be aware that the order in which you present your effects may produce different changes in your client, or different patterns of changes. Incomplete data, missing data. Example on page 272. Nope, wrong. Get the right page. Earmarked it. There you go, 273. You can see figure 11.2 where you don't have a lot of missing data. You don't have to worry about it too much. Down to 11.2c where in your baseline you have tremendous numbers of weeks where you don't have any baseline data, and this is problemsome. In this case you would simply say, really I don't have any baseline data, because of all the missing data. A researcher, if this was a classic research design, they would just go over and collect the baseline data again, and ensure that you didn't have any missing data, or you had very little missing data. Now that in a clinical situation may be impractical, so you may have to go on with what you have. But when you have that much missing data in a baseline, you really need to consider that really you don't have a stable baseline to compare to. Okay. Criteria for inferring causality. Earlier I said advantages of single systems designs is that you could determine whether an intervention caused a change in your client's target. Now, there are criteria for inferring this. First of all, of course, the cause must precede the effect. The intervention must start before you see the change. That makes sense. The co-presence of the application of the intervention and the desired of the target problem, so that there's a correlation between when you start the intervention and you see the desired change in the target problem. And let me give you, hold on. If you need some more information on this, it starts on page 277, the discussion, 278, and the discussion basically on 278, 279. 3, if target problems change for the better in the absence of an intervention, something else is causally related to the outcome. So if your target problem changes before you start your intervention, then you really want to find out what else is going on in the client's life. repeated co-presence of the intervention and the observation of the desired change. So if you turn on and turn off your intervention, like in an experimental design where we, try to go back to baseline and then do the intervention again, and that's the best way to determine whether or not that the intervention is causing the desired effect. When you turn off the intervention, that the problem reoccurs. Number 5, brings in other possible influences to test whether they may be the actual cause of a given change in the target behavior. So this can be done by discussions with your client. When you see a positive change in your client's problem, instead of assuming that it's your intervention, say, you've been doing better, and I know we've been working together, but what else is going on in your life? Number 6, intervention and change in target should be maintained over time. If it's truly the intervention that caused it, you should be able to maintain that over time. It shouldn't be a short-term thing. And then finally, causal inference should be grounded in scientific or scientific/professional knowledge. Is that there should be some theoretical basis that this intervention caused the change. That's why I'm having you, look at the research to see if these interventions are effective. And that adds to the your ability to say, okay, yeah, this intervention caused this change, and it's backed up by these studies. When we talk about, we've talked about measurement reliability and validity. When we talked about measurement validity, we talked about face validity, we talked about content, criterion, and construct validity. Now we're going to talk about design validity, and I just want to make that distinction. They're different, okay? And we're going to talk about 3 different types of design validity, and talk about the potential threats to causal inferences. And probably the one that sticks out that you recognize is threats to the middle one, internal validity. But there are a couple others that we're going to talk about. The first is statistical conclusion validity. And all that you want to determine there is, did change occur? And threats to that being true is if you don't have reliable measures, if you don't have a reliable implementation of the intervention. For example, you do the implementation at different times. Procedurally, you give different directions or different forms or things like that. You have random things going on in your irrelevancies in the setting. For example, one time, if you have a client, and sometimes it's hard to do if the client is collecting data at home, but you want to encourage them if they do it in a quiet room. If they do it in a quiet room one week and they do it in a kitchen table with the children running around after school the next week, then those are, your setting is not reliable. And then finally, the final threat to whether did change occur is if you have fewer observations. The more observations, the better. Obviously, and that's why we encourage you to get more than one baseline point, because you can always, catch somebody on a bad day. And the same thing during the interventions. We want to have as many observations, as many measurements as we can, because that creates a more stable picture of what's going on. Okay, internal validity. Was the change caused by the intervention? Now, this is the one that you probably heard definitely in Research 1 and your undergraduate research. May have been a while, but hopefully you've heard of internal validity. Was the change caused by the intervention? These are the threats to that. History. History is simply other events in a person's life. For example, if you start your intervention and a person a couple weeks later starts not being depressed, and a week before that they get out of a destructive relationship, they win the lottery, there may be other events contributing to reduction of stress or things that could contribute to reducing their depression. So you have to know what else is going on in your client's life. A maturation. This is particularly relevant to children and adolescents. Some children and adolescents simply age out of problems. There's developmental milestones, and they simply age out of certain behaviors. And so you have to be aware of that if you're treating an adolescent over a period of time or a child over a period of time. Also, another example I like to use is, in college, probably doesn't apply to you, but some people imbibe in a lot of alcohol during college. And if we look at the alcohol use in college and then after graduation, you would probably see, on average, a great reduction, because there's this maturation process. There's this realization, I've got to get a job, I've got to get up at 8 o'clock every morning, and that kind of thing. So there's this maturation process that happens. Testing. Eliminate testing. Sometimes people remember how they responded last time to a standardized test, especially if it's a short standardized test, and that could include, the independent rating scales, and that could influence the responses the next time they take the test. So again, it's important to remind your clients every time, just be focus on the questions, stay in the present. There aren't any right or wrong answers. Don't be influenced by how, even if you remember how you answered this last time, don't be influenced by that. Try to stay in the present and answer the question honestly. Instrumentation. This is where you want to make sure you use the same forms, the same instructions, if possible the same administrators if you're administrating a test. So keeping everything the same. Dropout. Now this is more in a situation where you're doing a classic research design. Let's say you have substance abuse clients, and you're comparing, this is actual, let's say I'm going to set up a study and compare AA with cognitive behavioral therapy and control group. And at the beginning, they all have 50 people, okay? Now, AA, I want to proceed this by saying AA is a wonderful treatment model. It's helped a tremendous amount of people. It's helped some friends and relatives of mine. But it doesn't work for everybody. And some people are turned off by it. And as a result, I think that the statistics that I have seen conservatively say 50% of people don't come back after the first meeting or two. So that's dropout. So by the time, a 12-week period goes by, you have, let's say, 25 people in your AA group, and you're always going to have some dropouts. So instead of 50, you have 45 in both your cognitive behavioral group and, let's say, 46 in your control group. And the control group is like is people on your waiting list or something. That aren't receiving treatment yet. Now, the results, when we look at the pre and the difference between pre and post tests, AA looks like the most effective treatment. But because of dropout, what you can argue is that all the people that it wouldn't have worked on have dropped out, self-selected out of that treatment because it just wasn't for them. It just wasn't going to work for them. Whereas in the cognitive behavioral group, the control group, you didn't have that level of dropout. Regression to the mean. Regression to the mean is also called the bad day phenomenon. Let's say before you go take and this is why it's important to have more than one baseline point, because you could have extreme scores on your first meeting. Maybe that morning, you went out to your car and your battery wouldn't start. You got in a fight with your spouse. Just one of those days. So your scores were extremely high, and what we have found is that the more scores that we take, that the average score regresses to the mean, the true. I would say the true, the more of a representative level of that person's depression. And it can also happen on it has to do with extreme scores, so it could also, be a good day phenomenon. Diffusion or imitation of intervention. Let's say we have two examples here. Let's say we're working in a group home setting, and they live in different houses, okay? And they live in house, let's say, sometimes they give them, like, let's say the oak house and the maple house, okay? And somebody comes in and wants to try and a lot of these kids have anger management problems, and they want to try a new form of anger management in addition to the services that they're already receiving. So the Oak group receives an intervention called anger replacement therapy, ART, which is an actual therapy, and they implement ART with these Oak, these kids from Oak, and every these kids interact during their free time, during lunchtime, in the evening. And the kids in the SOWK group start talking to the kids, say Maple, and the Maple group during that time, and start telling them about art, and start telling them about some of the techniques that they're learning. Now, they're not learning, the intervention, the threat that we're talking about is called diffusion or imitation of treatment. They're sort of learning a bastardized form of it because it's not coming from the original practitioner, but they are learning some form of the treatment. So when you get at the end, you're not comparing a true control group to the art group, because some of that learning of the treatment has seeped into the Maple group. So that's an example of diffusion or imitation of treatment. Okay. My computer just went off, so I hope that didn't interrupt the, just went to standby, but hopefully that didn't interrupt the recording. We'll keep going. The next type of design validity is construct validity. Did you implement your intervention and measure your outcomes accurately? So the first one had to do with more reliability. This has to do with accuracy. It's important, I'm having you in your paper do using a multi-measurement package, and I ask that you use more than one measure and more than one type of measure. For example, not just using all standardized scales. You may be using a standardized scale, maybe using an individualized rating scale, a behavioral, or maybe a log. And then also, I also ask that you use more than one source. And it's sort of the analogy of the elephant, everybody grabbing a different part of the elephant, everybody sees sort of the different picture there, a different part of the picture. Another threat to measuring your outcomes accurately is hypothesis guessing by clients. Sometimes clients try to figure out what the practitioner wants, and they want to conform to this hypothesis or what the client or what the practitioner wants. So again, you just have to remind your clients, there's, this isn't, you just want truthful responses, and you don't, that there's nothing that you really want other than their honest responses. Evaluation apprehension from clients. Some clients and some students have apprehension when it comes to testing or evaluation. So you have to be aware of that, and sometimes they're afraid to tell the truth, and they may present themselves more positively. So it may be a good idea to see that, to understand whether your client has evaluation apprehension, if they have problems in taking tests, if they're concerned about the outcome of the test, what the test is going to say about them. Practitioner expectations. This happens when the client is able to perceive the practitioner's expectations. And this happens, maybe when you react to the results of an evaluation or a measurement taken. So again, it's just important for you to not to communicate any expectations you have of your client other than your client being honest with you. Another problem is interaction of interventions. Sometimes we use the kitchen sink approach, especially maybe if our client is in crisis mode. And if the client gets better, that's great. But the problem occurs is when you say, okay, well, let's start peeling some of these things away, and you're not sure which ones worked and which ones didn't, because there's an interaction effect, and you don't know what interventions worked and which ones didn't, or if the interaction of the interventions are what worked. External validity. And I want you to ignore what the book says about external validity. It's very convoluted, and this external validity is very simple. External validity is simply, can your results be generalized? And generalized, when we talk about generalized, can your results be generalized to and threats to external validity? These are threats when you have unrepresentative client samples. For example, if all your client samples are the same, if all your practitioners are the same, if all your settings are the same. For example, all your settings are inpatient in one clinic, and then if you're looking at CBT, if all your if the research that you're looking at has cognitive behavioral therapy comes in different forms, different dosages and everything, and we want, sometimes it's useful in saying, okay, cognitive behavioral therapy works, and it works, here's a 6-week program it works in and a 12-week program, so it can be generalized across time periods or dosages, if you will. So the way to enhance generalizability is to replicate an intervention across relative clients, across different types of clients, different practitioners, different settings, and different time periods or dosages. So going back to the previous slide, can your results be generalized? You want to be able to generalize them again across different client samples, practitioner samples, settings, and time period. I guess I just duplicated that, but that's okay. And this is mainly, this is a problem in single system design because you're just dealing with one client, one practitioner, one setting, and one time period. So this, when we talk about external validity, we talk about it in terms of a body of work, a body of single system designs, or we talk about it in terms of classic research. If classic research designs interventions have been tested on a variety of clients, different practitioners, different settings, and different time periods. So, and that's chapter 11, so I'm going to stop it.